Okay, welcome to our next video in this second lesson that serves as an introduction to the cardiorespiratory system, more or less focusing on the heart. In this video, we are going to cover the Wiggers diagram, and as you will recall from previous video that I produced, this is something that I expect you to know the features of in some detail. So this is something that I would suggest that you study, okay? And we are going to go through it step by step, hopefully in an understandable manner. Okay, so I wrapped up the last video by talking about the force of contraction and how it increases with calcium and how the action potential causes that to happen. What happens when the cardiac cell contracts is you get ventricular systole. And what this Wiggers diagram does is it goes through the cardiac cycle as you go from systole through diastole and then to systole again in terms of some fairly relevant things to you as a physician. So let's take a look at this in detail. First of all, notice time goes from right to left here, and a typical cardiac cycle, somewhat less than 1 second. If the heart rate is 70, if it's 60, it will be exactly 1 second. So this is in milliseconds here, all right? On the y-axis, we have our EKG. We have the pressures in the arteries, the aorta, the left ventricle, and the left atrium, okay, in orange, red, and purple here. And we have left ventricular volume here, and we have heart sounds. So immediately I think you can recognize this and this are things that you are going to deal with probably for most of you every single day of the rest of your lives once you hit the clinics. This you will also deal with. It may not be as apparent, but this change in aortic pressure, that's what's causing the pulse. When you take a pulse in somebody. So you need to be pretty familiar with these parameters and how they relate to the cardiac cycle. That's what the Wiggers diagram tells you. That's why I think it's important. And so let's talk about what's going on here in some detail. Whoops. First of all, I do want to emphasize to you, when we talk about systole and diastole in the heart, we are, unless we specify otherwise, we're talking about ventricular systole when the heart is contracting, ventricular diastole when the heart is relaxing, okay? And I do want you to recognize that. A typical question I get is, are you talking about atrial or ventricular? Atrial systole, of course, being when the atrium is contracting. Unless it's otherwise specified, this is what we are talking about, all right? All right. So let's start here. We have ventricular systole here. I ended my last video by talking about contraction of the cardiac cell, contraction of the ventricle, and ejection of blood into the aorta, which you know happens from previous video. And right here, we begin, and it's during ventricular relaxation. And you'll notice this dashed line right here takes place when the red line and the orange line cross, okay? And of course, during ejection, the aortic pressure is lower than the ventricular pressure, okay? It's exaggerated in this diagram. It's basically really pretty much not measurable, very difficult to measure. But nevertheless, you know, because blood is flowing from the ventricle to the aorta, the blood pressure is higher in the ventricle than the aorta, and that is what you see here, high ventricular pressure, lower aortic pressure. But because the ventricle is relaxing, the ventricular pressure is falling, and eventually it falls below the aortic pressure. And where these two lines cross, that is the point at which the aortic pressure becomes higher than the ventricular pressure, and blood wants to flow at this point from aorta to ventricle. But we know that that doesn't happen because the aortic valve is there, and the aortic valve closes when the aortic pressure exceeds the ventricular pressure. So the aortic valve is closing here, and you'll notice that when it closes, you hear a heart sound. The heart sounds S1, S2, the scientific terminology being lub and dub. lub dub, lub dub, lub dub. Okay, so we hear dub, S2, when this aortic valve closes. And on the right side, this is where the pulmonary valve closes. All right? And that sound is associated with the closure of those valves. All right? It's actually the rumbling of the walls of the aorta that you're hearing. You know, the great vessels of the chest, the aorta and the pulmonary artery. Okay. So that's your first heart sound. That takes place when your semilunar valve closes. All right. Now, your ventricular pressure continues to fall because your ventricular muscle is relaxing and the pressure is going down in the ventricle. And eventually the ventricular pressure falls below our purple line, which is the atrial pressure. And at that point, our left AV valve, our mitral valve, opens. If this is on the left side of the heart, but the same things are happening on the right. In the right, it would be the tricuspid valve. Okay? And the pressure falls below the atrial pressure. The mitral valve opens on the left, and you get blood flow from high pressure to low pressure from the atrium into the ventricle. And you'll notice that the ventricular pressure gets really, really low when the ventricle relaxes. It gets almost down to zero here. So your pressure is dropping and it's staying below that atrial pressure, and you're getting blood flow. And there you go, it falls almost to zero, and then it starts to come up again. And it comes up again because the blood is filling with, the ventricle is filling with blood. And as it fills with blood, the pressure goes up in the ventricle as it fills. You can see that gradually happening here, gradually happening in the atrium as well, because it's in communication with the ventricle. Blood continuing to flow, okay? And next you will notice this hump. It's here, and now let's go over to the right-hand side of the graph. See this hump here. This increase in pressure is due to atrial contraction, okay? So the atria contract, and what they do is they shove that last little bit of blood into the ventricle. They count for something like 20% or less of the filling. And you can see the filling goes up a little bit here. Here's our left ventricular volume. You can see it's increasing during filling, and then we get a little bit of a last-minute increase due to the atrial contraction here. And then you'll notice we get the red line crossing the purple line again. In this case, the red line is going to be above the purple line. The ventricular pressure exceeds the atrial pressure. What happens at that point is that the mitral valve closes. Blood wants to flow from the ventricle back into the atrium. The valve is shoved closed, and it prevents that blood from flowing, and we get an increase in pressure as the ventricle continues to contract. And notice this little lump here. This is S1 in our heart sounds. This takes place in association with the closure of the mitral valve on the left and the tricuspid on the right, and it's due to the rumbling of the walls of the heart when that happens. Okay? Our pressure continues to rise. Ventricular pressure eventually exceeds aortic pressure, and the aortic valve opens, and blood flows from the ventricle into the aorta from high pressure to low pressure. And we get ejection of blood into the aorta, and that causes an increase in pressure here. So our minimal pressure where that valve opens, about 80 millimeters of mercury. Our peak pressure during ejection, about 120 millimeters of mercury. Your blood pressure, 120/80, okay? All right, notice this area between the closure of the mitral valve, or the tricuspid, and the opening of the aortic valve. On the right, it would be the pulmonary valve. During this period, both valves are closed. The aortic valve is closed, it opens here, but it's closed during this period, and our mitral valve is closed during this period. So both of our valves are closed, and because both valves are closed, we know the volume is not changing, but the pressure is going up. So we call this isovolumetric contraction. Isovolumetric because the volume is not changing, but nevertheless the muscle is contracting and the pressure is going up. So this period has a special name, okay? And we get ejection of blood, and eventually our heart starts to relax again, and the ventricular pressure falls below the aortic pressure, and our aortic valve closes, and we get our famous dub here, and the cycle begins again. And notice as this pressure falls here, our aortic valve just closed, and our mitral valve is closed during this period. So again, both valves are closed. So this is isovolumetric relaxation. Isovolumetric, the volume of the ventricle is not changing, but the pressures are dropping in the ventricles because the heart muscle is relaxing. And then eventually our mitral valve opens again, we begin filling, and it all starts all over again. Okay? All right, look at our EKG. This change in the EKG is called the QRS complex, and what that means is that the action potential is propagating through the ventricular muscle and initiating contraction. When it propagates through the ventricular muscle, you generate this QRS complex, all right? And you will notice that that is associated with the beginnings of the increase in pressure here, and it's associated with our famous dub here, okay? So this is the beginning of ventricular systole because it happens when the action potential is propagating through the heart and initiating contraction, okay? You will also notice this T wave. This takes place when the ventricles do what's called repolarization. That is, the action potential stops propagating through the heart. The depolarization of the heart is stopped, and now the heart is returning back down to the resting potential. When that happens, the muscle begins to relax, and we see the end of systole and the beginning of diastole. Okay, so your T wave is ventricular relaxation. It's the initiation point for that, and that means that diastole is started. Okay, you will also notice your heart sounds once again, lub and dub. S1 in association with closure of the mitral valve when the ventricular pressure exceeds the atrial pressure. S2 in association with closure of the aortic valve when the aortic pressure exceeds the ventricular pressure, and you should recognize that that is when that happens, all right? Okay, so let's go back to our dilated cardiomyopathy patient. The first thing you'll notice, the ejection fraction, 5 to 10%. When you look at these ventricular volumes, you can see that that is extremely bad. Because when you look at the changes in ventricular volume here, you start at roughly about 130 milliliters, and you drop to roughly about 50 milliliters. So that means you're ejecting, during a normal cardiac cycle, about 80 milliliters. 80 divided by 130 is 0.61. Your normal ejection fraction, that is the amount you eject relative to the amount that you start with, is about 60%. 10%, much lower than that. That ain't good, okay? So once again, there's some application there. So let's take a look at our echo, our old friend. And one thing I want you to notice, see these walls? If they were contracting in such a way that you were ejecting 60% of your blood, they would be moving like this, big movements, okay? So that, you contracted and you got rid of more than half of that blood. Notice how they're only moving just a little bit. That is because this is diseased muscle. It is not contracting well, okay? There are other reasons as well, but nevertheless, this is abnormal. This wall is barely moving. It's only changing the volume of this ventricle about 10%. That's not good. That's very abnormal. You should recognize that, all right? All right, that's our Wiggers diagram. Thank you for your attention, and we'll move on from there.